Welcome and good morning, everyone. Today is Thursday, May 24th, 2012, and you have logged in to Best Doctors webinar series for Physicians by Physicians. Thank you all for joining us. My name is Eric Glazer, and I help lead physician engagement and social media here at Best Doctors. I am joined by my colleague, Dr. Lou Levy, the Vice President of Corporate Medical Quality, who will be part of an esteemed panel of clinicians, all of whom we will formally introduce in just a moment. Today's one-hour-long panel session is entitled, How Medical Collaboration Improves Diagnostic Accuracy. This will be an overview of the Best Doctors clinical consultation process. And our panel is going to provide you with an overview of this process and how we leverage the clinical process to improve diagnostic accuracy. Each panelist represents a key function within this process, and each individual will explain to you their role and perspectives in their own words. If we do our job successfully this morning, at the end of the hour, you have a good understanding of both the Best Doctors business model and our clinical process, and be able to self-select programs you may be interested in participating with us in. Today's session is being recorded and will be available on demand. For those of you who have never heard of Best Doctors prior to this webinar or simply think we are a list that gets published in your local magazine, I want to briefly clarify what we do. Best Doctors enables physicians to work together in an innovative new way to ensure that the patients receive the right diagnosis and right treatment. And our goal is to draw on the experience of doctors, like many of you, to make really what's wrong with the healthcare system right. And with your help, we can provide patients with the best access to the best medical advice from the world's leading physicians. And in doing so, we aim to restore what you loved about medicine and reinforce the reasons you originally became a doctor. We were founded in 1989 by two doctors, two Harvard Medical School professors, with the purpose of supporting physicians in identifying the right diagnosis and right treatment for their patients. We earn our revenues when Fortune 1000 companies like Pepsi, Home Depot, or Hertz hire us to assist their employees in three general areas. We help their employees in identifying the very best doctor in a particular specialty or subspecialty. So basically, we're sending referrals to our best doctors. And we also answer employees of our clients' clinical questions. But what we're best known for is providing employees with the right answers to questions associated with complex clinical cases. And this comprehensive review of a case is what we call here at Best Doctors an interconsultation. And this is a collaborative process that involves multiple clinicians and often in complementary disciplines. And to support this patented process, we identified the best of the best specialists around the globe through peer polling. And these are our best doctors. And that's most of you listening in on the webinar today. So what I want to do now is introduce to you Dr. Lou Levy. He, as I said earlier, oversees our medical quality, and he will explain at a high level how we conduct these interconsultations. Lou, in addition to leading our medical team here in the U.S., is also a practicing internist with over 20 years of clinical experience at Harvard Vanguard Medical Associates in Boston, and in his spare time is an instructor at Harvard Medical School. Lou earned his medical degree from the University of Rochester School of Medicine and Dentistry and completed his residency in internal medicine at the Graduate Hospital of the University of Pennsylvania. You can submit your questions to Lou and any of our panelists, and we'll be introducing our panelists one by one down throughout the presentation today. You could ask questions to Lou or any of our panelists through the WebEx console to your right. I believe everyone should have a Q&A window to their right. If you're having trouble finding that, by all means, email me directly. My email is at the bottom of most of these slides. It's eglazer@bestdoctors.com, and I will be monitoring my inbox and taking questions as they come in. So Lou, I'm going to hand it over to you. You can take it away from here.
Thanks so much, Eric. What I'd like to go over this morning is how Best Doctors does what we do. As Eric pointed out, we are a global company serving approximately 34 million individuals around the world. We have offices both in the U.S. as well as in Canada and in Europe, Australia. And we have a very comprehensive way of getting at clinical information when folks reach out to Best Doctors. And what I hope to do in the next 10 minutes is really go through our process. We also have the good fortune this morning of being joined by Dr. Sorrentino, a practicing cardiologist, as well as Dr. Bill Wood, a practicing oncologist, who are very much involved with the Best Doctors process, and they'll be able to give you a little bit more detail in terms of the various steps that we're about to go through. So, as Eric mentioned, please feel free to ask questions of us at any time during the presentation. So how do we do what we do? Best Doctors in the U.S. is typically offered as an employee benefit. So large companies such as Boeing, Northrop Grumman, Home Depot, Procter & Gamble, Merck, all have Best Doctors as an employee benefit. And what that enables all of the employees at these companies and their family members is the ability to call Best Doctors should they be faced with a serious medical situation. Very recently, we had a woman who reached out to Best Doctors. She was recently diagnosed with cervical cancer. She had a very large mass that was in the pelvis, had invaded the local bowel. She wasn't getting better on chemotherapy. It was through the Best Doctors process that we learned that, indeed, it wasn't cervical cancer. This was actually a case of colon cancer. The basic pathology had never included immunohistochemical staining, and that staining, which was done at the MGH, revealed that this poorly differentiated adenocarcinoma was colon in origin, not cervical, and obviously she had been receiving incorrect chemotherapy. She got on the right therapy, and she's actually responded very, very well. So in a case such as that, the first step would really be that the patient, or member as we call them, would reach out to us. They will have a very comprehensive clinical intake done, and we have actually joining us this morning both a member of our intake team, Kara Connor, as well as a member of our physician services department, Tracy Littlefield, who will go a little bit over their roles as well. Following that very comprehensive clinical intake in which there's a thorough review of the patient's current history as well as relevant past medical history, we really go to work in terms of a very comprehensive medical records collection. This can take sometimes 2 to 4 weeks. We don't just assist the members in the collection of their medical records. We actually collect all the medical records on their behalf. They sign out various release forms, and then we have a large department of over 50 individuals who basically that is their full-time job, going across the globe, collecting medical records, collecting radiology, collecting pathology. We have a team of physicians. Dr. Bill Wood is part of that team who goes through these records and really creates very concise clinical summaries. These are very academic and really detail for the expert the key features of the case. Importantly, they also include about 10 to 15 questions to the expert. We feel as though we get the best out of our experts by really being very specific in terms of the type of information that we want to glean from the case rather than saying, what's your overall impression and plan in terms of what should we do here. We retest pathology, so that was very important in this most recent case. The pathology really revealed that this was colon cancer, not cervical cancer. We also have a cloud-based imaging platform where we directly share the CTs, MRIs, and other radiologic information directly with the experts. So when they're opining on a case, they're not just relying upon a radiologist's report. They're actually seeing the films through a dedicated viewer. We have an algorithm by which we select the experts. In this case, it was a top expert in terms of colon cancer. The expert, and Dr. Sorrentino will get into this a little later on in the presentation, will go over all of the clinical summary and the questions and provide their comments. They'll develop their expert report that would be appearing on their actual institutional letterhead. We have a quality team. Dr. Wood participates in this as well, where once that expert report comes back, make sure it's evidence-based, make sure that all the questions were thoroughly answered, and make sure that there were references to the recent medical literature provided. We then deliver that expert report both to the member as well as to their treating physician. We review the report with the treating physician. This is a collaborative process. It's not medical legal. It's not utilization review. It's really a way of, through this platform, delivering what we see as the very best in terms of medical expertise and also case preparation right at the point of care. We then follow up with the member. At 3 weeks and 3 months, we want to make sure if Dr. Sorrentino has put forward certain suggestions, we want to know were those suggestions actually integrated into the patient's plan, because we don't want to be in the book report business. We really want to be helping in a collaborative way the ongoing care of the member. We have found through our book of business, over 95% of the time, our recommendations are put into practice. The result, about 39% of the time there is a change in diagnosis, and 60% of the time there's a change in treatment. And that's basically the Best Doctors process. I'd be happy to pause and take any questions that folks might have. Okay, so why don't we charge ahead here. It's my distinct honor to introduce Kara Connor. Kara has been a really wonderful member of the Best Doctors team for the past 5 years. She's a graduate of Curry College. Prior to Best Doctors, she worked as an RN in critical care, urology, orthopedics, trauma, and general medicine at the Massachusetts General Hospital in Boston. She is a distinguished teacher, in addition to being a distinguished member of our nursing staff, and she maintains her staff privileges at the MGH and is the Director of Clinical Services at Best Doctors. And with that, Kara, take it away.
Thank you, Dr. Levy. So the main role of the nurse case manager is that of support and advocacy to our members from start to finish. So we are with the member from the beginning of the case all the way until the end. But also that one of our main responsibilities is to complete the medical intake with the member, which is essentially a telephone interview. And this can take anywhere from 30 to 60 minutes depending on the medical complexity of the member's condition. So we review the member's history of present illness, current symptoms, past medical history, family and social as well, current medications, any treatments the member has had to date, as well as responses, and most importantly, diagnostic testing and pathology review when applicable. So essentially, throughout the life of the case, the clinical nurse manager works with the clinical team, that medical record specialist, as well as the lead physician, but really our goal is to ensure that all of the essential medical information is collected in order for a comprehensive case review. So our goal, in essence, overall, is really just to make certain that our lead physicians have the information available to them in order to prepare a case for expert review. So overseeing the case from start to finish, working with the member, and ensuring that all medical record collection is complete for our lead physicians. And
Sorry, Kara, go ahead.
Physicians on the phone today is Dr. Bill Wood. He is an assistant professor of medicine at the Lindbergh Comprehensive Cancer Center at the University of North Carolina at Chapel Hill. His practice is in stem cell transplantation, leukemia, lymphoma, and myeloma in the Division of Hematology Oncology. He completed his residency training in the Harvard Combined Residency Program in Internal Medicine and Pediatrics. obtained his medical degree from the Duke University School of Medicine, and earned his BA at Harvard University. He also holds a master's in public health from UNC.
Kara, thanks very much for the introduction. Can everybody hear me okay?
Yeah, you're coming in well, Bill. Actually, let me, since you handed me the mic for a second, I just wanted to remind everyone that you can continue to ask questions. We are fielding them. I see them coming in fast and furious, and at some point through the flow of today's discussion, I'll interject with questions for the panel. So keep them coming in through the Q&A module to your right. Go ahead, Bill.
So, Kara, thanks again for the introduction, Eric, Lou, and everyone. Thank you for the opportunity to contribute today. I was asked to speak for a few minutes about my role at Best Doctors, which I think that Lou has summarized very well in terms of what I do with data synthesis and aggregation, clinical summary creation, review of the clinical summaries and expert reports, and additional QA/QC. I've been involved with Best Doctors actually since I was a resident at the Brigham and Women's Hospital in Boston, and have continued my involvement throughout my residency and then subsequently through my fellowship and my first couple of years on junior faculty. And when I think a little bit about sort of what I do and why I continue to do it with Best Doctors, I can think of a couple main reasons that contribute to that. And the first, I think, is that this provides me an opportunity, becoming very involved in these cases, to participate in a process that I think really leverages the Internet and the intellectual capital of our expert pool to provide really sophisticated consultative opinions to patients who are literally all over the world who are looking for our help. And I think that when we do this, and as I've really become aware of firsthand through the clinical summary process, I think we have a unique opportunity in medicine to really get it right in terms of doing complete data collection and comprehensive reports that, frankly, are difficult for anyone to do in the scope of usual medical practice, and then in terms of the limited time that we have with our patients every day. And the second important reason I wanted to bring up is that I think that this provides really immense intellectual engagement and satisfaction that contributes to my own learning. As Kara had mentioned, I'm a practicing oncologist in academic medicine. Many of the cases that I get involved in are actually complex oncology problems. And I think that this gives me a chance to contribute and also to be informed as a practicing oncologist. And I just wanted to bring up two recent cases that might help to illustrate that a little bit. One was actually a review in which I participated as preparing the clinical summary and reviewing the reports for a middle-aged woman who had presented with an ovarian mass, which was found to represent an endometrioid adenocarcinoma, which ended up being correctly surgically staged, and then observed there was an area in a periaortic node that unfortunately began to grow on subsequent scans after chemotherapy. And she ended up undergoing surgery again. She was retreated with chemotherapy, and the case was eventually reviewed through our process by Dr. Arlen Fuller, who had been the head of gynecologic oncology at MGH. And Dr. Fuller reviewed the totality of all the records that have been collected from diagnosis through the time that the case came to our attention, and I think made a couple of very interesting points about how this focus of disease was likely to be residual rather than a true relapse, and based on some of the receptor staining, recommended consideration of both local therapy to the disease as well as hormonal therapy to try to bring her back into a longer remission in a potentially less toxic way. And so I thought that was actually very interesting to me and informed my own learning and hopefully provided a useful service to both the patient and her treating physician. I've also had the distinct privilege to work with some of the real experts in my own personal field in stem cell transplantation and lymphoma, including Dr. Anton at Dana-Farber, who is really a true international leader in the field of bone marrow transplant. And in doing that, I've really had a nice opportunity to work on some very complex cases that have been directly relevant to my own practice and that have helped to inform me of very recent data that's been presented in my field at some of the national meetings. So this has been very enjoyable to me, in addition to what I think is hopefully a very helpful service for the people who are looking for our help. I'd be happy to take any questions about that either now or later during the panel discussion. Otherwise, I would be more than happy to turn over the microphone to Tracy Littlefield from our Physician Services Department, who can summarize her role in a little bit more detail.
Let's do that in a moment, Bill. There are a couple of quick questions that I want to address and ask you and Lou very quickly and tackle them. One of the first questions, Lou, I'll start with you, and then Bill, you could chime in. Is a question from our audience: is can we work quick enough to provide critical care opinions?
In general, yes, we can. We really try to make this be a very comprehensive yet also responsive type of process. So we have been able to turn around on certain cases expert opinions within a 24-hour time period. However, I would say more typically, because it does involve this type of deep dive comprehensive medical review, I would say that the typical life of a case would typically be in more of the 4 to 8 week time standpoint. But again, we have had cases that have literally been turned around within a 24-hour window.
Thanks. So, Bill, do you have anything to add from where you sit as the one that sort of sits in the middle of that process?
Sure, absolutely. I think that I fully agree with what Lou has just said. In addition, I would note that I think one of the nice features of our process is that we maintain ongoing contact between our nurses and our patients, and that allows us to have, I think, a good feel throughout the case for the needs that the patient and his or her treating physician have for the information. So we can stay in touch with that and do our best to meet those needs in terms of providing actual information that will inform decisions that need to be made. And then the second point I would briefly bring up is that, again, since I do a lot of cases within oncology, which intuitively seems like an area where it's quite critical to get the information in time, I would just say anecdotally that we've really been able to provide, I think, some very sophisticated opinions that do inform fairly time-sensitive needs in these areas. So this is a process, as Lou said, that does take some time because we do want to make sure that the data collection is complete. But my own experience has been that we've been able to do that in a way that really does helpfully inform decisions.
Thanks, Bill. And then circling back to you, Lou, very quickly, are these consultations always office-based? The attendee asks or mentions none of the companies you mentioned at the very beginning of our presentation are likely to have employees living near me. So I thought, Lou, maybe you could provide some clarification there.
The cases come from all over the country, and the collection of medical records comes all over the country, but all of these medical records are then gathered together in Boston, where they're scanned and put into electronic file folders so that they are then available for our reviewing physicians. But at Best Doctors, it's a virtual process. So I just want to make that clear that we are not actually seeing these folks in the Boston office. We are collecting their medical records, organizing those records, summarizing those records, and having them go forward for expert review.
Yeah, and I may have caused some confusion. I'll clarify one point that I made at the beginning is we do refer our employees to physicians in their local area when they call us and ask for a referral. But that is a separate service from the interconsultation process that we're outlining right now, which Lou just described is done remotely.
Yep.
So, Bill, I'll hand it back to you to introduce Tracy.
Sure. Thanks very much, Eric. I really am distinctly privileged to have an opportunity to introduce Tracy Littlefield, who is a very valuable role has a very, very valuable role in our Physician Services Department. Tracy is a 15-year hospital nursing veteran. She's a skilled educator and an accomplished author. She earned her Bachelor of Science in Nursing with high distinction from Curry College. She's a member of the Massachusetts Nurses Association and Heart Rhythm Society. She's currently on staff at Brigham and Women's Hospital, and also, as I mentioned, a Physician Services member advocate at Best Doctors. And I'll give Tracy an opportunity to describe her role in the process a little bit further.
Well, thank you, Dr. Wood. Can everybody hear me okay?
Hear you perfectly.
Wonderful. So just to describe what we do as nurses here in the Physician Service Department is that we receive this internally prepared clinical summary by our internal physicians, like a physician like Dr. Wood, and we take this clinical summary and we review this for completeness and accuracy, and we coordinate available diagnostic images, pathology reports, other diagnostic reports, and we're able to share these with our experts. So essentially what we do is we provide an accurate, relevant clinical summary that has content applicable to this case. So it's essentially like this final QA evaluation of a clinical summary. So then we use our keen eye based on years of experience and sophisticated algorithms to use our expert database and case matching. So our case matching, we want to have our clinical summary match an expert case match perfectly. So what we do is we focus on engaging physicians' interest and their specialty and within their time constraints. So things that are important to us are quality. Quality matters. Our expert reports are approved and scored by our internal team on things like content and insight. So based on these metrics, we consider academic affiliations, publications, clinical trials. These things are all considered in case matching. And, you know, it goes beyond just this. It goes beyond the desk. It also includes networking, developing solid relationships with our experts, and really act as that point person between best doctors and the expert, so a liaison, if you will. So from that point, I'm going to actually turn the mic over to Dr. Sorrentino, who can speak to authorship of reports. Dr. Sorrentino was voted our best doctors on our Best Doctors America list back in 2007. He's a general cardiologist at the University of Chicago, where he also earned his medical degree and did his residency. Dr. Sorrentino has expertise and research interests in treating hyperlipidemia, hypertension, and coronary artery disease. He treats patients with all types of heart disease and risk factors for heart disease. He's a popular speaker, and Dr. Sorrentino has been invited to give lectures and run education programs at more than 500 local, national, and international meetings and events. He's written numerous publications on preventative cardiology, including a recent book, Hyperlipidemia in Primary Care.
Well, thank you very much, Tracy. It's great to be part of this panel today. And as many of the listeners have heard, by the time the process gets to the expert, by the time I get the case report, really all the hard work is done. The Best Doctors process supplies me with a written summary of the patient materials. It's similar to getting a CPC in the New England Journal of Medicine. So it's very well outlined, very complete, but also to the point. So I could easily read through the case report and understand what the symptoms are, what the past history is, what the issues are. And then I have the ability to look at images. So through the website, I can look at cardiac catheterizations, look at echoes, look at chest x-rays, look at EKGs, because I find it's very important to have the primary data if you're going to make a judgment on what type of advice to give to the patient and to the patient's doctors. My area is cardiology, as Tracy mentioned, especially preventive cardiology, but I have a very large clinic here at the University of Chicago where I see all types of cardiovascular cases, and so the cases that I get from Best Doctors usually have a myriad of cardiac issues. And they can be sometimes just straightforward cases where what needs to be done is not always entirely clear. For example, I recently had a case of a 63-year-old man who had a murmur heard on a routine physical exam. An echocardiogram showed that he had moderate to severe aortic insufficiency. He didn't have any symptoms, but the LV was slightly dilated, the aortic root was slightly dilated, and there was a question, should he go to surgery or not have surgery? So by able to look at the echocardiogram, look at those measurements, verify that they were correct, and then go back to written guidelines. We could easily see if he fit into a category of watchful waiting or a category of needing surgery, and we can give that that opinion to the patient and to the doctor. And I think that's one of the parts of this process which is really exciting for me, is you can look at a case and then go back to some of the primary literature, some of the guidelines, and it really verifies the guidelines both in my own practice and in giving opinions to the different patients and the different physicians. Of course, another area that is very common in cardiology is what do you do with a patient who has known coronary artery disease and is having some symptoms? Is this patient somebody that should go for interventional therapy or bypass, or should this patient be treated medically? Another case I recently reviewed was a patient who had had an acute MI. His left anterior descending artery was completely occluded. He had some symptoms that had gone on for 6 months after his MI, mostly of kind of lethargy and fatigue and occasional twinges in his chest. His LV function was fairly good. EF was 49%, so he hadn't had a major reduction in heart function. But the question was, should his physicians try to open up this artery or bypass this artery, or was it okay to continue to give medical therapy? But what was important about the process is all of the other past history that was included in the case. Turns out he hadn't been exercising, he was deconditioned, he was significantly obese, he had sleep apnea. So there were multiple reasons that could tie into what his symptoms were. And both by reviewing the literature on the results of trying to open up an occluded artery and come to a conclusion based on that, and then looking at some of these other symptoms and coming up with other very strong possible reasons why he was having his symptoms, I think we could redirect his physicians onto how to approach thinking of this patient and treating this patient. The reason why I like being involved in Best Doctors is it really continues what I love to do. I have a very busy clinic where I love to see patients, make diagnoses, try to make their lives better. I've been an educator here at the University of Chicago, so I love teaching. As you heard, I give CME courses and lectures all the time, and this is a way that I can continue teaching at a much larger level. And I also feel that it's important to really try to promulgate the guidelines, get preventive modalities out there, and so I try very often in these cases to redirect patients to how they can change their lives, how they can incorporate some preventive modalities into their lifestyle, which many times can bring about significant improvement in symptoms, significant reduction in risk, above and beyond just some of the therapeutics that we do and some of the procedures that need to be done as well. Every once in a while, I get a really interesting case, that is something that I haven't thought about or hadn't come across recently. I had a case about 6 months ago of a patient with Ehlers-Danlos syndrome, and although I've seen a couple of cases of them through my career, it's not something I see every day, and so it also teaches me a lot. In that case, I needed to go back to the literature to learn some things or reintroduce myself to some things again, and so for me, it's also a fantastic learning process to hopefully improve my own clinical understanding of cases as well. So, Tracy, I guess that's kind of an overview of how I see it as an expert. As I mentioned, the work is mostly done. I get a great summary of a case. It's very infrequently that I have to ask for more information. Usually all the information is there. It's easy to read through a case in a fairly short period of time, get the essence of the case, and the important thing is the questions. The questions really focus my thinking about the case, and by directly answering the questions, it really doesn't take that long to come up with the expert report because the questions focus me on what is asked, and I can answer them very quickly then.
Thanks. Thank you, Dr. Sorrentino. It was terrific. I will say to everyone, in about 5 or 10 minutes, we're going to start addressing more of the questions from the audience. We have at least a handful of them that have been submitted. And at some point, I'm going to flip over your slides that you're looking at to a feedback form. It's this digital form that you could just click and answer some yes/no questions or some multiple choice questions. And it's our way of gaining feedback from all of you. And one of the things you can request besides a copy of the slides from today is a copy of an expert report and a clinical summary. So you're looking right now on your screen at, as Dr. Sorrentino alluded to, the questions that are posed to him by our internist. That's an example of a screenshot of a clinical summary. We could send you a full one along with an example of an expert report. So if you haven't done a case for us or aren't familiar with this process, you could have something tangible to see what the output is. Prior to just jumping into the questions, I do want to give everyone an overview of some of the other programs that we're involved in with our expert physicians beyond just the InterConsultations. We are also launching a new clinical platform. It's going to be a social platform. We're calling it an online community that we're going to be conducting our consultations in, where doctors are going to be able to share information, review images, do a lot of the things that Dr. Sorrentino alluded to, but a little bit more of a social and collaborative setting, and we're looking to find some of our experts who are interested in actually testing that out and working with us and giving us feedback. So that's one way you could work with us beyond just the cases. We also just launched a pilot program called Best Doctors TV, and we put it on YouTube. So if you go to youtube.com/bestdoctorstv, you'll see that we have a few channels based upon specialty that we've produced featuring our expert physicians answering frequently asked questions of patients. And we're going to look to expand the amount of specialties we cover, as well as expand the amount of questions within each specialty that we're addressing. And certainly if you're interested in being part of the social media phenomenon and want to have a presence on YouTube, as well as be able to reach patients in need of critical information that you can provide, we'd love to work with you throughout this summer and into the fall and even into next year on being part of Best Doctors TV. We'll also have internal monthly meetings where we're conducting global grand rounds, just like you would at your hospital, where we have an expert featured each month talking to our internal clinical team, and we'd love folks who want to participate and be speaking at our internal meetings. And we also would love at future webinars if you want to be a panelist. We're producing content on a monthly basis around topics tied to diagnostic accuracy and certain specialties, as well as talking about various different challenges and opportunities around communication amongst clinicians. You've probably seen some recent promotions around doctors participating in social media, and we've hosted those and brought doctors on who are using those tools. So if there's reasons and topics that you want to be involved in on our monthly webinars, we'd love to have you involved. And finally, we just launched a physician-facing blog called Curbside Consult that you could see. Actually, Dr. Levy has a post up there on diagnostic accuracy that we put up there just yesterday. And if you want to be someone who wants to guest post for us on a topic relevant to diagnostic accuracy or your role as a best doctor, we'd certainly be very happy to work with you on that. So you could contact me at eglazer@bestdoctors.com, and we'll get on the phone with you and we could talk more about that. Actually, during the feedback, there's a question. You could click off any of these programs that you want to work with us on. So let me get to the Q&A now, and in a moment we'll put up the survey as well. A question that came in earlier that I didn't want to interrupt folks, and I'm going to start with Lou on this, but Matt, get ready because you're going to be next. I'm going to ask you both this question. In your opinion, how does a process like this improve diagnostic accuracy or clinical outcomes? So Lou, I'll start with you and see if you could tackle that.
Well, I think that the two basic components of the Best Doctors process that really help to improve diagnostic accuracy are, one, the comprehensiveness of the medical record collection process. As I think folks who are participating this morning well know, there's tremendous fragmentation of medical information. Very few doctors' offices have electronic medical records, and even those who do, it doesn't really account for the fact that folks in those practices may have done a fair amount of traveling around for the past 5 to 10 years. So I think that a key part of our process is just getting all of the data in-house. And then the second key feature is really that there are many cardiologists in the world, but then there are cardiologists in the world who have particular expertise in terms of understanding not just the key features in terms of the cardiac disease, but also the key features in terms of preventive medicine and things that the patient might be able to do in terms of trying to keep themselves well in the future. So by being able to identify doctors such as Dr. Sorrentino to really opine on cases and really tap into their expertise is another key feature of our program. And I think that really, having that united data along with a doctor with really not just another opinion, but really an expert opinion are really key features. And I think that is why, Best Doctors has been so well accepted by the treating physician community. I've had the fortune of being able to travel to Europe and Canada and Australia and New Zealand and speak with treating physicians who've received Best Doctors reports, and they really enjoy getting these reports. They're well researched, and the expert is often experts that doctors in the community have seen lecture at major meetings. So I think that these reports are really quite well respected.
And Eric, I think the other aspect of it is, as an expert, we're able to sometimes look beyond the obvious. Many cardiac cases revolve around a patient having chest pain, and of course the first thing we think about is chest pain is due to ischemic heart disease, but of course chest pain can be due to many different factors. And by having the full history that goes back sometimes many years, we can many times come up with a differential diagnosis and a much more obvious cause of chest pain. Recent case that I saw was a patient who had recurrent chest pain. Stress tests were normal, angiograms were normal, but one angiogram showed that when the catheter was placed in the artery spasmed a bit around the catheter, and the patient had been diagnosed with coronary artery spasm. But we know that sometimes that can just be catheter-induced and is not really spasm. And so this patient was on a lot of treatment trying to prevent spasm, none of which was working and causing the pain. And so by looking very carefully through the history and through all of the data, we were able to pretty definitively say this was not coronary spasm, and it was due to other processes that the treatment could then be refocused. So I think by having all the data in front of us and going back sometimes many years and sometimes across a number of different physicians, we can come to a more precise possibility of what the cause of the symptoms are.
Right. And this next question, I'm putting that very related. Bill, I'm going to start with you, and then Matt, I'm going to circle back to you. What do you, and we answered this a little bit, but what do you think are some of the advantages of this process versus a, quote, traditional second opinion, unquote? So, Bill, why don't we start with you?
Sure. Thanks, Eric. Absolutely. So I think that, one clear advantage for the patient is really in terms of convenience. If you're thinking about obtaining a traditional second opinion and purchasing a plane ticket to go wherever it is that you'd like to go, I think that the beauty of this process many times is that the intellectual expertise can be brought to the patient through this process. But I think that in addition, I do provide some traditional second opinions through my own clinical practice. And when I think about what this process is like in comparison to my day-to-day experience, I think that number one, as we've already been talking about, the data aggregation is key. Many times I'll have most of the data when I'm seeing somebody for a traditional second opinion, but I often find that there's key elements that I wish I had and that I have later and try to then reintegrate into my assessment. And it's nice through this process to know that that is pretty much comprehensive and complete through what we do at Best Doctors. I think that's very helpful. I think another area that's very helpful is that in the traditional second opinion, again, I think this is all within the context of sort of experience as part of daily practice, which is sometimes pretty busy, I think, as anyone who's in practice knows very well. And I think that by taking this process at Best Doctors kind of offline from that, doing this at a time that there's sort of careful reflective review and extra time to formulate these opinions, such as the excellent ones that Dr. Sorrentino provides, I think that the end product is fairly comprehensive. And I think that the final piece I would add is that by having the clinical summary in front of you, or in front of me, I would imagine, not that I'm a best doctors expert, but having created the clinical summaries, I'm imagining that creates a more consolidated way to look at the past history as opposed to, again, trying to bring in these disparate data elements from in a traditional way in usual practice. So those are a few areas that come to the top of my head, but I'd be happy to talk more about that.
So I agree, Bill. One of the things I really like about this is it's a little bit more leisurely than typical second opinion. When I'm done with this conference this morning, I'm going to go to my clinic. I'm going to have about 20 patients to see this morning, and inevitably some of them will be second opinions, and I have 15, 20 minutes to try to decipher all of the data and come up with a second opinion. With Best Doctors, I've got the time. I can carefully look through the summary, see how all the bits of data fit together, and then if I have some questions in my mind, I can turn back to the literature, I can turn back to guidelines to, form the best opinion. So for me, it makes the process more leisurely, more intellectually rigorous. I can back up all of my findings with what the guidelines say. If I want to vary from the guidelines, I can pull key papers and talk about how these papers would apply to this patient. And so to me, it's a much more intellectually satisfying than rushing through my busy clinic to try to get these second opinions out.
And, geez, the questions are pouring in. So what I'm going to do right now is I'm going to put up this feedback form as a reminder to everyone. This is an opportunity to actually request more information about any of the particular programs, including these consultations that you'd like to be participate in. It's also an opportunity for you to be able to provide us with some feedback on how we did today and what other content we could cover on our monthly webinars. So we really appreciate the 3 or 4 minutes it would take to complete this. I'm going to continue going through the Q&A. We keep on getting questions submitted, so there's a bunch more, and we'll try to get through them in the next 13 minutes. Lou, I'm going to start with you on this next question, and Matt, I'll circle back to you. What are some of the limitations of this approach, if any?
Well, I think that one of the obvious limitations is that if there's ever a situation in which a detailed physical examination needs to be done as part of one's evaluation of the patient in terms of really getting at the diagnosis, because this is a virtual process, we are really dependent upon the physical examination as it is reflected in the patient's medical records. So on some of, I know that Dr. Steffens has written in on the chat box that her specialty area is in pediatric rehabilitation and neuromuscular disease. Some of those disorders are very complicated, and sometimes it does require, although we've had some great cases and have tapped into the expertise of Dr. Hirano, who's the medical director in the lab of metabolic and mitochondrial disease down at Columbia, and Dr. Amato, who's the vice chair of the Department of Neurology at the Brigham. But sometimes we really do need to have that detailed neurologic exam in order to really pinpoint the diagnosis. I think that another limitation of this process, and one that we do mitigate for, is that sometimes we do have therapeutics available in the U.S. that are not always available globally, but we do have physicians in various countries who do try to work with our members in terms of, not only identifying best care in the U.S., but also best care locally as well.
Before we circle to Matt, Lou, you mentioned one mitigating kind of tactic. Are there other, in the overall limitations that you cited, are there other things that we do to mitigate limitations?
Well, I think that the main way that we really mitigate the limitations is through the process that Tracy had kind of gone through earlier, that we really are very careful about our expert selection. I think that there are many experts who are really terrific doctors and great in terms of the face-to-face, but struggle with this type of process. And I think that what needs to be very carefully laid out is that because one does not have the privilege of the face-to-face interaction, one does not have the privilege of, that direct examination, one does need to be fairly careful about qualifying those recommendations to make sure that while they are specific to the patient, they're leaving enough leeway that the patient understands that this is a collaborative process and one in which those recommendations can very often be integrated in terms of the treatment plan, but one has to be somewhat careful to not be overly dogmatic in terms of those recommendations. So I think that another way that we kind of mitigate in terms of the overall uncertainty of this kind of virtual process is through careful selection on the expert side.
So Matt or Bill, a number of questions coming in, but I do, if you want to add to that, I'd love to hear your take on that, and I'll quickly circle in and try to get a couple more questions in before we hit the half past.
Well, this is Matt, and I agree with Lou that the main limitation is we're not seeing the patient. 90% of the time, you can understand what a patient's problem is by a very careful history. And there are times where you wish you can go back and ask that one or two additional questions of the patient to better characterize their symptoms, characterize their chest pain, characterize their functional capacity. Because many times in my own practice, the way I determine what's going on with a patient is just sitting and talking with them very carefully and understanding what their symptom complex is. Now, having said that, what's been very useful is that the history is usually very well written, and what Tracy and the colleagues are able to give me is not only just the history of the present illness, but a very good social history, which certainly helps. So a lot of the questions that I'm thinking of when I'm first reading the history many times are answered as I go down in the case. And then many times there's copies of the physician reports that the patient has seen, which will give me more insight. But it's really the focused history is so important because most of the time that'll tell you what's going on.
I think those are all, from my standpoint, excellent points. From the standpoint of a process in terms of, what else that we've tried to do to mitigate some limitations, I think about the kinds of information that our experts need to come up with these opinions and whether or not we're providing all that information. And I think that we are continuously looking at that in terms of ways that we can improve on process. So, for example, when we think about delivery of chemotherapy and metastatic cancers, one of the most important factors is the functional status of the patient, and as many know, that can be formally measured in a couple of different ways. So in thinking about that, we've started adding ECOG performance status to our clinical summaries to help to provide that kind of information for experts as they're considering the case. And we do other kinds of things like that all the time to try to really make sure that the information that's being delivered is the right information. On the other side, I think that it's important to understand how the patient is getting the information that comes from the report. Sometimes the opinions, though written in patient-friendly ways, can be fairly technical and detailed, and so we mitigate that many times by a report delivery process that involves our nurses, and sometimes I'll be involved, or my internist colleagues will be involved on those calls as well to make sure that there's been a summary provided of the report as well as an opportunity to answer questions that might come up about it.
All right, so Bill, don't rest. I got a follow-up question for you, and I'm going to circle back. Actually, I have a question for Kara coming up after that, so I'll let Kara kind of stretch out and get ready, and then we may have time for one more question beyond that. Bill, attendee asks, first states, most diagnostic errors are more difficult than a wrong tissue diagnosis in cancer. Many of the problems are chronic, at least in pediatrics, and have no simple ICD code. So how often is the feedback to the patient, we can't help either?
Right. Well, I think that's an excellent point. I'd like to kind of backtrack for just 2 seconds to say, many times though we've talked a lot about diagnosis, the issue is more complex than that. And even if we've agreed on a diagnosis, there's lots of different subtleties to treatment plans. And it's not to say that one is necessarily superior to another, but I think that bringing in an expert opinion, as I think about what I learned as a practicing oncologist, it's another take on a situation that I think informs me and helps me as a practicing doctor to be a better doctor. And I think that that's helpful. I think that I'm always of the opinion that I can use all the help I can get, even if I'm fairly sure in my diagnosis and treatment plan. And I like to think of this as a collaborative rather than an adversarial process. I think that's very helpful. But with regard to the question that the participant has brought up, this does happen sometimes where we say all the right things have been done, and unfortunately we just can't figure out a way to fix this particular problem. And sometimes even that information is helpful, I think. Many times our patients come to us because they want to make sure they've left no stone unturned. And this provides some peace of mind to know that they've had a second set of eyes sort of looking at these kinds of problems, and there's some consensus and agreement among all the different people who have reviewed the case. It's not always a very satisfying answer in terms of a long-term plan, but it gives us something to work with as we can then talk with the patient, and their treating team can talk with the patient to say, there may not be an obvious answer here to fix this problem, but now let's sort of work on kind of managing the situation that we do have.
Thanks, Bill. Kara, quick question for you. How well received are these expert reports, and how do you measure patient satisfaction?
So the expert reports are very well received by our members. Part of the process is that we review the reports with the members to ensure that they understand the content and that they are actually taking these reports back to their treating team, especially when there's recommendations for further testing. So they're always very well received. They sometimes have questions in regards to content, but overall very well received. Each of our members is followed by a satisfaction survey at the end of the case. So we track member satisfaction case by case via these surveys that we get each week.
Thanks, Kara. Great. And Lou, are these available for independent research? In particular, there's been an attempt to relate your recommendation. In particular, has there been an attempt to relate your recommendations to apparent change in medical status? Of course, this is preliminary data, but it forms the basis for study outlines.
Yes, so that is actually a very new effort that we've recently began a collaborative relationship with some leaders in the field of diagnostic accuracy out of Hopkins and the Brigham principally, and we hope that within the next 12 months we will be able to have some studies coming out that are really showing some trends in diagnostic accuracy as we can see through a snapshot of the thousands of case reviews that Best Doctors does each year.
Thanks, Lou. We're just about done here. I want to remind everyone on the call if they could just take a couple of minutes to provide us some feedback on the form right in front of them. Last question of the morning for Matt. What are some final words of wisdom or advice you can provide our audience, these Best Doctors experts, in the challenges and benefits of working on our cases?
I think the main thing is have fun with it. This reminds me back to when I first started medicine, and I was intrigued by trying to make a differential diagnosis, putting a puzzle together, and really trying to understand a case. I remember as a medical student, I loved reading the CPC reports in the New England Journal of Medicine, and it is like going back to that. The process is fairly easy because as an expert, we're given all the information. It can be done in a reasonable period of time. I frequently do it at the end of the day, sometimes in the evening, sometimes on weekends. Sometimes when I have a spare hour in the middle of the day, I can do a report. But it instills that intellectual rigor again, and it's just fun doing it. So I think one of the reasons we all went into medicine was the challenge and the learning and the teaching, and this is a great way to do that again.
Thank you, Matt. Appreciate it. And I want to first thank everyone who took the time this morning prior to their busy day to join us. So I really appreciate it. We know your time is very valuable. Thank you to our entire panel. You guys were terrific, and I know you're all very busy too, so I appreciate you taking the time to join us and to help share your insights and experiences. A shout out to our production team behind the scenes, Amy Robinson and Kelly Slump. Thank you very much. This will mark the end of our session. We hope to see you on another one of our webinars, depending on the topic, but we'll have one every month, so look out for communication from me around what our next topic is. Thank you very much, and to all, have a very good rest of your day and have a very good long holiday weekend coming up. Take care now.
Thanks, everybody.
Thank you.
Thank you.
Thank you.